Marco, and Ankur for encouraging me to share some experiences from the Self-Employed Women's Association on primary healthcare through women's collectives. As we all know, we are passing through a particularly turbulent period in our human history. The COVID-19 pandemic and now the war in Europe and in other places are having significant impact on all of humanity. At such times, I turn to Mahatma Gandhi, whom we in India call Gandhiji, for solace and for guidance on the way forward. I did not know much about Gandhiji except for my school textbooks, but I found Gandhi's message through my work at the Self-Employed Women's Association, SEVA. It was only then that I understood how relevant his message, his values, and his ideas are for life and living, and especially for the poorest and most vulnerable in our country, the women workers of the informal economy in India. They have shared their struggles and hopes with me for almost 4 decades now, and I hope to share some of those with you today. Thanks to this talk, I revisited some material, some views of Gandhiji's on science and on health. He often said, science without humanity is one of the 7 sins. His well-known talisman, which many of you would know about, was that he advised us that the poorest and most vulnerable in our society should be central to all our endeavors. In fact, it is they who should be guiding all action and all action on health. Recently, I came across Key to Health, a book he wrote in 1906 in South Africa, then entitled Guide to Health, and reprinted in 1942 when he was incarcerated in Pune, and with a new name, Key to Health. Gandhiji says this has been the most popular of all his writings. He advises, and I quote, anyone who observes the rules for health mentioned in this book will find that he has got in it a real key to unlock the gates leading him to health. He will not need to knock at the doors of doctors and vaidyas, which is our traditional medicine practitioners, from day to day. As usual, he was prophetic and ahead of his times. I feel we need to revisit these ideas for preventive action on health, most especially as we grapple with the current COVID-19 pandemic, and of course, a whole host of other health issues, including oral health. Without even knowing about this book, we've been working on many of the ideas Gandhiji wrote about over 100 years ago. And hence I thought it was fitting to borrow the title of his book for this talk today, The Key to Health. Another reason for starting with Gandhiji's ideas is that they have inspired not only our health work, but also because his values inspire all that we've been doing for the last 50 years now at SEVA. Satya, or truth, ahimsa, or non-violence, sarvadharam, equal respect for all faiths, swadeshi, focusing on local production and consumption, among other values, have been our guiding principles for all action at SEVA. When in doubt, we remind ourselves of his vision for Swaraj, generally translated as self-rule, which is not only obtaining our political freedom, but also eliminating poverty, exploitation, and injustice, and putting ourselves, and especially the poorest, firmly on the path to self-reliance. The informal economy in India has always been predominant, even in Gandhiji's time. It contributes significantly to our nation's GDP, to our savings and exports. Informal workers are over 93% of the workforce. Perhaps we can have the first slide, Ankur. They are mostly self-employed, like small farmers, artisans, and street vendors. You see the sister, the SEVA sister there in the slide. She's a salt farmer. an own account worker, manufacturing salt in the little run of Kutch. There are millions of women like this across the breadth and length of India who are contributing actively, as you can see from the figures, to our economy and to our society. They have little or no work security, nor income security. My sister in the slide works long hours under the hot sun for very meager income. While food security has improved over the years, food of sufficient quantity and quality is still a struggle for many, especially women and children in our country. Social protection coverage, including healthcare, childcare, insurance, pension, housing with a tap and toilet in every home, is still limited, and millions of workers in the informal economy, even today, remain unprotected. Can we have the next slide, please? Within the informal workforce, as I mentioned, women are the poorest and most vulnerable, like the women you see in the slide, planting rice or rolling agarbattis, as we call them, incense sticks. They generally get the work that is most hazardous and with very low remuneration. There is an overlap between informality, poverty, and gender in India. And also most of the women you see in the slide and millions of others come from the most socially disadvantaged communities and castes in India. And they are 94% of the female workforce. It was to remedy these injustices, to face the challenges and stand by our sisters in the informal economy, that SEWA was established in 1972, 50 years ago today, by Ila Bhatt, a labor organizer and lawyer. Born into a family of freedom fighters, she was deeply influenced by Gandhiji's call to serve the poorest in rural areas. Later, she joined the Textile Labor Association, a trade union of mill workers in Ahmedabad, which was founded by Mahatma Gandhi himself and a remarkable woman of our city, Anasuya Sarabhai, one of the first Indian women to go overseas and study at the London School of Economics. The Textile Labor Association was set up in 1918 in the city of Ahmedabad, where SEWA is located. It was there that Ila Ben, as we call Ila Bhatt, was first exposed to the world of work of the majority of the Indian workforce, and particularly women. Supabai, a head loader from the main wholesale cloth market, approached Ila Ben in the early 1960s for support in the struggle for minimum wages with the wholesale cloth merchants for whom they worked. Moved by the plight of Supabai and other women like her, who carry loads on their heads for barely a few rupees a day, Ila Ben began to organize them 50 years ago. Organizing, in our experience, is the process of uniting workers and building their solidarity for collective action and through their own collectives like unions, cooperatives, self-help groups, farmer-producer organizations, and many more. Supabai, the head loader, led other women head loaders in negotiations with the cloth merchants with Ila Ben's support. There was no SEWA at that time, but Ila Ben was standing by Supabai in this first effort at organizing informal workers. It led to wage increases for women, and also to the creation of a tripartite board with representatives of the Labor Department, the wholesale cloth merchants, and the workers. This board continues till today and provides welfare benefits to head loaders, in addition to fixing wage rates. At SEWA, informal women workers are organized on the basis of work and livelihood and include women from all communities, castes, and creeds. SEWA was registered as a union and is now a national union with 2.1 million informal women workers across 18 states, the first of its kind in India. We soon realized that different strategies were needed when organizing informal women workers, most of whom were self-employed and therefore had no fixed employer-employee relations, as you can see in the slide. When women said they needed financial services to free them from the clutches of money lenders, and when the nationalized banks in India at the time, remember this was about 5 decades ago, when the nationalized banks refused to open bank accounts for women, 4,000 women contributed 10 rupees each from their daily income as share capital and formed their own cooperative bank in 1974. They were among the pioneers of the microfinance movement worldwide. Today, Seva Bank, a cooperative bank, has over 500,000 depositors and working capital of 5 billion Indian rupees, all from small savers, our members. Seva Bank has now helped millions of women to save, obtain loans for their businesses, and get access to other financial services like financial literacy, pension, and insurance. Following this first effort at creating solidarity through a cooperative, we realized that this is a powerful strategy to organize women. As we organized women in the 1970s, we found that it was very hard for them to strike. And in any case, as I said, most of them were self-employed. So who could they present their demands and needs to? Therefore, to increase their bargaining power in the labor market, we began to form collectives, mainly cooperatives, as in our home state of Gujarat, there is a strong cooperative movement already. And even then there was one. We've also experimented with different forms of organization in other states, because in some other states in India, cooperatives are not so easy to register and to set up. Today, we have more than 150 formally registered collectives, all membership-based organizations within the Seva movement, and thousands more with informal village-based self-help groups and community-based groups. Maybe we can put up the slide, the third slide, which is a summary of some of what I've been saying. But you can see these are the kinds of women who we are working with. As Seva grew, women said they needed basic health care. They told us our bodies are our only assets. As long as we are healthy and can earn, we can feed our families and hope for a better future for our children. The need for this and the gap in even basic healthcare emerged starkly, actually, from the experiences of Seva Bank, where we found that there were a number of women who were not repaying their loans regularly. And when we delved deeper into this, we found the major reason was sickness. In fact, one study we did in 1977, we found that of 500 women who were not repaying their loans regularly, 15 had actually died due to causes related to childbirth. It was then that we were galvanized into action, beginning with a maternal health program and a maternity benefits program, where extra nutrition was provided to our members. And then finally, the Gujarat government took this up as a scheme to support landless agricultural laborers, and that was implemented for some years. I joined Seva to develop a community-based, women-led primary healthcare program for Seva members and other informal workers, and to address the huge gap in healthcare that emerged from the Seva Bank study. Remember, I'm speaking about almost 40 years ago, when we did not have the National Health Mission in India, when we did not have a strong public health system, and mainly ours was a family planning system. The first thing that struck me was the lack of scientific information among poor women on the body, on illnesses, and how to stay healthy, especially required given their meager resources and limited access to healthcare. My first 6 months was spent observing and learning in a sprawling neighborhood, Shankar Bhuvan, on the banks of the Sabarmati River in Ahmedabad. Women in Shankar Bhuvan were all informal workers, mostly street vendors, scrap metal collectors, domestic workers, and some even cleaned used tins for a living. They would scrub them clean. They had been organized into our union, and many had accounts in Seva Bank. Some had taken loans and had already developed their fruit, vegetable, and scrap metal businesses. I also learned that in urban Ahmedabad at the time, people had more faith in their local healer called Bhuva. I witnessed some of the Bhuva's practices in Shankar Bhuvan, some quite scientific, like the use of herbs and turmeric, and others which were downright harmful. When a young woman was abandoned by her husband and her baby girl was taken from her, leading to depression, the Bhuva made a fire with red chilies and made her inhale it to remove the spirit that had possessed her. Another young woman suffering from mental illness was locked up in a room and fed scraps that were thrown at her till we convinced her family that all she needed was love and care. Tuberculosis was widely prevalent, but people were afraid to get checkups and were not aware that free treatment was even available. Despite our efforts, several women did not survive. When we linked up with the municipal authorities for free TB medicines, women said they did not have the time to queue up for these at the hospital. Who would bring in the income to feed their children? And anyway, they could not afford proper food when taking the antibiotics. I had been taught about the social, economic, and political factors influencing people's health in public health school. But here I saw it playing out in real life. Women told me, and I quote, "We would like to be clean, but our turn to bathe comes once in 3 days. Water is a problem here, and our toilet is the riverbank. We get up at dawn before our menfolk." The social determinants of health, or rather lack of them, like water and sanitation, could not have been more evident. Primary health care, and with a preventive focus, was the immediate need then, as it continues to be now as well. The current pandemic has yet again brought this home to us, and also the high cost in lives and livelihoods that comes from not investing in primary health care, with secondary and tertiary care to back this up. Primary health care includes action on the social determinants of health, including water and sanitation, nutrition, early childhood education, gender equity, and so on. Our members advised us to start by educating them on health and setting up a creche for their young children so that they could go out to work and the children would be well cared for and safe. We did both. Later, the creche that we had set up was taken over by the government's integrated child development services and continues till today. A few of the women stepped forward to take health literacy classes. Of the first 10 health workers, only half knew how to read and write. It was challenging to develop ways to support their learning through practical demonstrations, repeated training sessions to ensure that women got the information they needed, and constant refresher sessions. It was a slow but exciting process of discovery and mutual learning. When we had a session on anatomy, we were surprised how much women knew. They said it was because they reared goats and ate them as well. I remember well Suman Ben, one of my mentors, never been to school, but a datan or toothbrush vendor, explaining how she felt after one of our training sessions. I've had 6 children, but had no idea about my body and all that happens during pregnancy. How could I if no one ever shared this knowledge with me? She also told me, women like me have to have 4 to 6 children so that 2 to 3 survive. She was both student and teacher, and soon began sharing her new knowledge with thousands of others like herself. Along the way, we learned how to present scientific information on the human body and on diseases in a simple manner, demystifying medicine for local people, especially women. These health workers began a program of health literacy in Shankar Bhuvan, where our health work began, and soon it spread to other parts of Ahmedabad and the rural areas as well. Interestingly, we found that our health work encouraged more informal women workers to join SEVA, as they found this health service useful low cost, and appropriate. Thus, health action was an important part of our strategy of organizing workers and building their solidarity for collective action on health and on a whole host of other workers' issues. When we had a core team of 50 community health workers, we decided to form a health workers cooperative. By 1990, Seva had considerable experience in cooperatives, and so we thought, why not form a health workers cooperative? When we went to the cooperative registrar, he was horrified. He said, what will you earn? What will you produce? How will you ever be viable? It took us 2 years to convince him, but finally, in 1990, we had our health cooperative, Lok Swasthya Seva Health Cooperative. This cooperative took the collectivization approach of Seva to the health sector, uniting women for awareness on health, leading to action at the local level, and leveraging their collective strength to actually obtain the primary healthcare services offered by the government mainly, but also by private facilities and practitioners. Soon after, a revenue-generating opportunity presented itself to us in the health cooperative, Lok Swasthya Seva. We realized that in our discussions with women that medicines were burning a hole in their pockets. They were using up whatever they had earned through their hard-earned money for out-of-pocket costs. And we therefore began a small counter with just 70,000 rupees working capital, a counter to provide low-cost quality control generic drugs to our members. We bought the medicines from the wholesale medicine market and made these available to our members. Soon after, the municipal authorities asked us to replicate this model in their own hospitals and provided some seed capital for this. And today we have 3 pharmacies, 2 of them running 24/7, all run by women outside 2 large public hospitals. And at the same time, this has become a model for the government's Jan Aushadhi and other generic medicine initiatives. From our profits, we also began an Ayurvedic medicines production unit as we found these were cheaper, locally acceptable, and with fewer side effects. Each of our batches is quality tested, and now we have a good manufacturing practices label, which is provided to us by the government. Maybe we can put up slide 4. Thank you. This is the last slide. As most of you are dentists, I'll just put this up because you can see the young women learning about the body. It's just a quick summary of some of what I have said. Maybe we can take the slide off now. Yeah. As most of you are dentists, I should share some lessons on oral health, which we learned in the course of our health journey. It goes without saying, and you would all know, that oral health is a low priority in India. Our members find dentists expensive, and in any case, they're not available in many rural areas. So what we did is our health cooperative decided to prepare traditional toothpaste, which we call Dant Manjan, in our Ayurvedic production unit. And this has become one of our highest selling products. And the feedback we get from women is that it's both effective and low cost. Another issue, interestingly, that we encountered and that we saw repeatedly, that our older Seva members, once they lost their teeth, we saw that their nutrition and health declined because they couldn't eat much. So what we did was we incentivized the use of dentures in our insurance program. So those who took out long-term insurance with our health cooperative, Seva's insurance cooperative, also got access to free dentures as a benefit. One of the challenges we faced in taking science and basic healthcare to informal women workers was their belief systems. Many times these were barriers. I remember when we went into villages 30+ years ago, the villagers put thorns in our path, literally put thorns in our path, and women took their children and ran away. They didn't want immunization. They didn't want vaccination, not unlike what some of us have faced during the coronavirus. But now things, of course, happily have changed and developed quite well. Bringing healthcare to local people by women in a manner that is both appropriate, both from people's point of view and that of science, is not always easy. Tuberculosis, or TB, as I mentioned earlier, has always been a top priority. And we were keen to work with our municipal corporation and with the WHO to bring tuberculosis control through the DOTS method right to women's and their families' doorsteps. It took us 2 years again to convince the authorities that it was possible for local women frontline workers to take up this challenge. Finally, we trained local women to look through a microscope to identify bacilli, and then, of course, with the support of a doctor, start them on medicines. And it was a proud moment when these frontline workers, we call them Agevans, were felicitated by the same Ahmedabad Municipal Corporation and authorities who had doubted that these women could do anything in the first place. There's, of course, a lot to share, but I'm interested more in your questions. So I'd like to perhaps go to some of the lessons learned all these years, and then we can open up for questions. I think the first lesson that I'd like to share with all of you and others on this call is that it's critical to invest our time and resources in taking scientific knowledge, including on oral health, to people, to the local level, decentralized level, to the grassroots. Surely the current pandemic has driven it home to us like never before. In his book, Key to Health, Gandhiji suggested, and I quote, "We must in the first place know enough about the human body." I especially like his view. The human body is the universe in miniature. His book is replete with suggestions on what to eat and how, the importance of air, water, and self-restraint in our food intake and in all aspects of life. He warns very early on against the use of tobacco and advises the use of jaggery rather than refined sugar. There are practical suggestions for well-being, and a common vein running through the text is for us to take charge of our own health, self-care and care of others, just as he often stressed self-help at the village level. Surely these insights during the pandemic continue to be most valuable for all of us. As I mentioned earlier, not knowing of this book, but following his other ideas of going to people, especially the poorest, we began our health literacy initiatives. It continues to be the most important aspect of our primary healthcare work. It is painstaking and often seems repetitive and slow, but it's the slow and steady work that few are doing, certainly not our public health system. What we've learned from this health education work is that putting knowledge in people's hands is empowering. Equipped with new information and knowledge, there's now a spring in the step of our health workers come health educators. They are respected in their communities for all they know and for the services that they offer in saving lives. Several of our health workers have been asked to stand for election in local self-government and are also serving their communities in this way. The second lesson is that the health and well-being can be achieved, at least in part, through solidarity created through women's collectives. As many of our Seva sisters say, who would know about us and our struggles? It is only through organizing, uniting, and building up our own organizations. And it's not only for visibility. It's also a practical way to reach services and entitlements to the poor. It's much easier for the government officers to ensure outreach and in a transparent manner if they are interfacing with the collective rather than individuals, more so in times of a pandemic like what we are going through today. Next, through collectives, women and other vulnerable sections of our society obtain strength, the encouragement they need to learn and to break barriers, and even alter power relations in their families and communities. Collectives provide an opportunity for women to come together and learn collectively. For example, they begin to alter gender relations from the new knowledge and new insights that they develop. Also, this new scientific knowledge brought into the home by women and shared with their children and other family members gives them a new status in the family. Everyone benefits from their newfound confidence and ability to challenge some of the patriarchal views on women and their health. Third, we have learned that when we place faith in local people, especially women, and their ability to learn and serve their communities, we are rarely disappointed. Not only are they ready to serve, but they do so in an appropriate, timely, and low-cost manner. They are quick to adapt to digital technology if internet and devices are made available to them. I've already mentioned how women quickly reached health information to local people during the pandemic and continue to provide health education. Fourth, the collective helps women address the social determinants of health, which we've already spoken about, only one of which is the health system. Others, like livelihood and early childhood care, need to be addressed, in my experience, can be best addressed by collectives or solidarity organizations of local people, and in our case, informal women workers. This is because it is very hard for an individual woman to advocate for better water supply and a toilet in her home or full-day childcare that will enable her to work and earn. But if she's part of a group, she finds the strength and bargaining power she needs to address these difficult issues. My sisters in Shankar Bhuvan, for the first time, negotiated with the Ahmedabad Municipal Corporation for toilets in their slum neighborhood. And from that, the municipal corporation then developed a full-fledged program providing 7 basic services, not only to the women of Shankar Bhuvan, but to the rest of Ahmedabad city, low-income neighborhoods as well. For all these reasons, then, I suggest that primary healthcare through women's collectives is the key to health. Building solidarity through collectives also results in inclusion, deepening of democratic functioning and decision-making, and participation, especially of those who are usually forgotten or excluded, like informal women workers. When they feel they have both agency and knowledge, they feel empowered to act on all aspects of their lives, not least their health and well-being. Of course, there are many other factors and aspects to be considered, but ultimately, equipped with appropriate scientific information and with the strength of the collective, women and local people can take control over their bodies and their lives. As we face the consequences of the COVID-19 pandemic, the tragic loss of life and livelihoods everywhere on the globe, and wars in various parts of our globe with far-reaching consequences, we would do well to remember the messages Gandhiji gave us long ago in his little book. They are ones that continue to be relevant and are a reminder how each of us can act for ourselves, for our families, for the common good of all in these challenging times. Thank you very much.
Thank you so much for a really inspiring talk. I have to say, I myself have learned a lot, and I think you probably covered everything that we would talk about in social epidemiology or social determinants of health, and creating a model that was all about empowerment, that was all about organization and advocacy, microfinance, intersectionality, how different things interact for people, and particularly around gender roles and attitudes, a big issue, which is sort of not looked at. So I've learned a lot, but it would be great if Rajiv and Burke and you can ask some questions about what do you think, what are your reflections from the talk? Burke? Oh yeah.
Hello.
Hello.
Hello. Thanks, Mom. It's very, very interesting and inspiring presentation. I'm really excited to be here. Thank you for being here yourself. So the presentation is really amazing. I mean, I was just thinking about how it is in India and then in other countries. I'm originally from Ethiopia, now based in London. So, and especially the one you talked about dentistry, as I'm a dentist anyway, and the one you talked about the herbs and how you produce toothpaste for the local women. It's really amazing. So I kind of think about, I mean, why don't we try in our country? So why don't we do something about it? And I just wanted to learn more about those things. And I'm also wondering if there is also any other way to extend dentistry. I mean, in maybe in a traditional way. Like I went to some rural areas recently back in Ethiopia, like about 2 months ago, and I talked to this local person who has a knowledge about traditional medicine, but he doesn't do it formally. So, and he told me about how they do, like how they treat dental caries. Like they told there is a worm in there, and then he claimed that he really saw a worm like coming out of the tooth. So I was just kind of wondering if there is any way maybe you can extend and maybe we also learn from that so that dentistry might not be like more expensive like anymore. So yeah, thank you. Maybe I'll come back with another question. So thank you very much. Thanks, Uncle.
Thank you. Ankur, should I make some remarks now or later? Yeah.
Sure. No, I think it's probably a good idea to make remarks as the questions come. So, yeah.
So thank you, Burke. And actually, I'm really glad that thanks to the Lancet's Oral Health Commission, we've been in touch with so many dentists. I've never been in touch with so many people in the oral health before, and all sorts of ideas are germinating. We are doing a longer term study, as some of you would know, but we're also doing smaller qualitative studies, and we are hoping to tap the rich experiences of our dentist colleagues in India, like Dr. Rajiv, and see what we can do to bring out also traditional practices, many of which are quite healthy. I mean, they do promote good oral health. And the other thing we're trying to do is to link up with dentists associations. So I must say I've been very open. And we've already run a couple of camps, oral health camps, where for the first time women have shown their teeth to a dentist right at their doorsteps. And so we're trying to see how we can expand this, document this, and perhaps take it to our government. We are just one organization of women. We are not the government of India. If we can take it to our state government and our national government, and just as we have now screening for non-communicable diseases, I don't see why we can't set up systems to better screen for oral health so that women simply don't have to go and have their tooth pulled out, which is actually the most common thing that happens in India, particularly in the rural areas. So some of the ideas are germinating, but what we would also like to do is to first understand as a first step from local women, from their families, what are the kinds of issues they're facing? How can we be helpful? That's kind of the first place to start, rather than sort of top down, imagining what we think people would like. Being consultative, and through the consultative process and the churning, I think the way forward for oral health in our country will emerge, and it must emerge.
Mm-hmm.
Currently, it's not part of comprehensive primary health care in the way that all of us would like to see it happen. But it will get there.
Yes, I hope so too. Thank you very much. I really congratulate you on the work you've been doing for the women, for everybody. And yeah, so thank you.
Thank you.
We have a long way to go as yet.
I had a question, which was, of course, based on the existing outcomes from the Seva program over the years, which may be reducing precarious employment, organizing, empowering, which is at health effects around nutrition and tobacco, it is very likely that you have already positively impacted oral health of people. We just don't know. We haven't really evaluated that. And sometimes that's the thing, that we don't really evaluate the health benefits of these programs down to every body part. Maybe not needed, but also sometimes the way oral health is like compartmentalized, you do need. What do you think, like what, in your opinion, do you think that that has been the case, that, well, with generally, if nutrition and tobacco control is being addressed by any program which is precarious, like addressing employment issues or access to material resources, I think they will definitely have spillover effects in terms of benefiting oral health.
I think you're absolutely right, Ankur. And, with our work, our health literacy work, health education work, and particularly on the harmful effects of tobacco and even sugars, we do see that women do step forward a little more for, even checkups if there's a lesion or something, just to make sure that, there's no cancer or something. But having said that, I must say, tobacco, for someone like me who's a public health worker, like all of you, I'm obviously firmly committed anti-tobacco person. We all know the harmful effects of tobacco, but at the same time, the tragedies in countries like ours, large numbers of women are engaged in the tobacco industry. Growing tobacco, processing tobacco, women always get the worst and most hazardous work. And when we speak with women, they're very nervous about this whole tobacco control issue because they're worried about losing their livelihoods. And there's been very few examples, I can't think of any really in India, where there's been provision of alternative livelihoods and skilling in any meaningful way, so that people can be weaned away from tobacco and do other kinds of work which pays well. So in some ways, tobacco is a double-edged sword for organizations like ours, because it puts women out of work particularly.
Yeah, and that's the reality. And I think like even just saying that clearly, is important, because we can't just rule out that there are so many people working in that industry without providing alternative sustainable options to them. So
that's right.
Yeah. Any other questions from Rajiv?
Yeah. Thank you, Ankur. Thank you, Mirai. So I have a question about social insurance, and Seva's work is predominantly known in the Indian context, more so as women's collective, but from a public health and health financing, it's very well known as a great example for social insurance. In your experience, how has it been to deal with oral health issues covering the social insurance? So India has many community-based models that have employed social insurance, and to a great extent that has been working. But like Ankur pointed out, that has not just been evaluated. But what has been your observations about including oral health in the social insurance, which is one of the biggest barriers for accessing oral health care, which is the affordability, and having a social insurance really makes it much easier. But I would like to know your thoughts and views about the observations of oral health in the social insurance, especially from the Seva experience.
Thanks, Rajiv. And unfortunately, we have not had any experience of oral health, linking oral health to insurance. When we approached the insurance companies, I should actually go back in a minute and explain a little bit what we are up to. But basically, we went, just like Seva Bank was formed, we went to the insurance companies about 40 years ago, and the insurance was nationalized in India at the time, and asked them to insure our members. And they said, sorry, you are bad risk. You get sick too much, you die too much. And we had to say, well, frankly, that's why we're here. Anyway, it took another years. Everything's to take long for the penny to drop. But anyway, we started 30 years ago our own insurance, since no one would have us. We started insuring ourselves, and then we linked up with some of the mainstream insurance companies, because unfortunately in India, there are very high barriers to getting a license. If you want to be a full-fledged insurer and include oral health, occupational health, and so on, then you need a license, and the license costs 1 billion Indian rupees, believe it or not. You have to show you have that much money. And part of our struggle has been with the regulator, insurance regulator in India, saying that if you want to extend basic insurance coverage to the mass of Indian citizens, then you can't have these kind of high barriers. These barriers are higher than even the European Union capital requirements. And many other countries like the Philippines have done well to reduce their capital requirement. And why I mention this is that, if we were able to be a full-fledged insurer, I can assure you that oral health, mental health, occupational health, all the things that are currently not included by insurance companies in the products they offer us, we would be able to happily offer and develop in a consultative manner as we do with our members. The insurance companies usually develop a product, usually with educated middle class, higher income groups in mind. And we find those products often really not relevant to us. Now we've got them to actually work with us and develop some products. They wouldn't even include snake bite and certain other accidents on the family farm till we push them. So I'm afraid oral health is still a ways away. But I'm hopeful that one day we are not giving up. We're locked in a debate and discussion with the insurance regulator in India. They will reduce the capital requirement, in which case we'll be a full-fledged insurer, including oral health, and I'll have more to share at that point.
That will be incredible. We can't wait to invite you for another talk when that happens, for sure. So, Vijay, are there any questions from YouTube or Twitter at all? I think you're on mute, Vijay. No question. Okay. Maybe the other thing before we let Mirai ji go for her tea or lunch is just thinking about how, like, I know advocacy is a strength of Seva and throughout at levels by women themselves who are part of the program, but also your group itself. And I'm just trying to see, like, with your now new role in the Lancet Commission for Oral Health, you mentioned like hints about thinking about a health insurance that does include oral health for women. But how do you think, like, you can actually, what serious gaps do you think are needed to be addressed, particularly in the Indian context, but similar context, if we were to include oral health as, health, like, you don't want to keep mouth separate from the body. And for some reason in our countries, or more generally, that has happened. Do you have any perspective, like in terms of from advocacy perspective, what is needed by dental public health people to make sure that it works? I think you're on mute, sorry.
Sorry about that, yeah. No, and please, all of you feel free to add because you are more knowledgeable than me on oral health. But my sense is that we need much more evidence. I'm in the equity group of our Lancet Commission on Oral Health, and we found very few studies across continents, particularly in the global South, which bring out the evidence and the importance of oral health. I think that's a major gap. And that's a gap that I'm hoping through our collaborative study with UCL and other partners in different continents and countries, I'm hoping that we're able to fill that gap. to be very honest, in my interaction with policymakers on comprehensive primary health care and so on, oral health is not on their radar at all. I mean, we have to put it on the agenda. And so I think that that's something that with evidence that people like yourselves in different parts of the globe can generate, not just Indian evidence, that of course, but also from other countries. I think, and also to learn what other countries have done, because there are other countries in the global south where this is also an issue. Affordability is an issue, accessibility to dentists is an issue. So I think we've got to do a lot more thinking, but before that, we need to generate a lot more evidence. And I'm hoping that this commission with a focus on oral health will be able to do that. And even beyond the commission, that we will have this joint study, as I mentioned, to generate much more evidence. Thank you.
Thank you. And Burke, you've asked some questions there on the chat. Do you want to, or do you want me to read it? Okay, so Burke is asking, we all know that people, especially women, our moms, do not care much about their health and seek treatment early on. What helped to open up to timely healthcare service? So really early healthcare. Burke, is that the question? Am I afraid? Okay.
That women don't really care about I think that's a common issue, health-seeking behavior, and it's a very deep issue because it's connected to how women themselves and society view women. And, I'm sure in countries where you all are from as well, I mean, women think about themselves last. If they have any money at all, they'll put it for the care of their husbands and children, and then maybe they'll think about themselves. I've had many colleagues who've had a fractured leg but don't go for care or don't rest, and they say it's because who will cook, who'll do this, who'll do that, who'll take care of the family. So I think, yes, you're right. These are structural issues that need to be addressed, and they cannot be addressed individually. That's why, again, back to the collective and building movements, and movements meaning not just women's movement for change, but also movements within men in our society, men and boys. And I think that we do see change. I'm comparing to 40 years ago when some of us joined the women's movement. But of course, we have a long way to go yet. But I think these are structural issues that, again, frankly, it sounds like I'm making a simplistic suggestion, but I think there's really no other way other than coming together, sharing experiences, encouraging others, telling women that you are worth it. You are someone who deserves it. They don't believe that. It's going to take a little more time. I think the younger generation of women are getting that. They're more articulate, they're more educated, they have more access to information and technology and social media, and they see what's happening in other parts of the globe. But it's going to take a while. But having said that, I have to say that compared to 40 years ago, at least in India, women's health and well-being and overall well-being is much more on the agenda than it was back then. So that makes me feel that there are steps forward, although clearly we have a very long way to go.
No, thank you for that fantastic answer. I think with increasingly the evidence also around gender attitudes and the negative impact it may have on mental health is a critical one as well at a population level. So really structural changes are needed in that space for sure.
And I just remembered one other quick thing to Burke's question, which is that, if we want women to go to a hospital or to seek care or whatever, then we have to create an enabling environment. And that includes childcare, that includes changing attitudes in the home so that men folk in the home will take care of the kids and other household duties. So we have our work cut out.
Well, thank you so much for this fantastic talk. I'm sure people would be looking at the recordings and asking more questions, and maybe I'll find that opportunity to direct them to you, the questions. But thank you so much. This was really inspiring, and I have learned so much. And I guess Rajiv and Burke would agree to that. And really, thank you for taking out your precious time for Goher and iCoher for this talk.
Thank you for inviting me, and I hope to learn more from you on this journey of oral health for all. So, thank you.
Thank you.
Thanks for organizing.
Thank you. Have a good day.